Welcome. In this explainer, we're going to give you a really concise and practical clinical update for managing intermittent claudication in your practice. Everything here is based on the latest guidelines and the most current evidence.
Okay, so here's our game plan. First, we're going to frame the big clinical picture of intermittent claudication, or IC. Then we'll get into the core treatments, and we're going to finish up with some really high-yield counseling points that you can start using with your patients pretty much immediately.
First up, the clinical picture. Let's really get to the heart of what that classic limp and leg pain is telling us about our patient's overall health.
Now, we all learned the textbook definition, right? It's that classic symptom of peripheral artery disease, or PAD. It's totally predictable pain that comes on with exertion, and then poof, it's gone within 10 minutes of rest. But you know what? The story absolutely does not end there.
Okay, if you take away only one thing, let this be it. When a patient comes to you with these symptoms, you have to see it as a massive red flag. That pain in their leg is a direct warning sign that their entire vascular system is in trouble and at high risk for a heart attack or a stroke.
So this means our goals as clinicians have to attack this from two angles. Of course, we want to help them walk further and feel better, improve their quality of life, but just as critically, we need to be really aggressive about preventing those major cardiovascular and limb events. We're talking heart attacks, strokes, amputations, and ultimately preventing death.
And this focus on systemic risk leads us right to the most effective treatments. And the key thing to remember here is that the most powerful tools we have aren't actually found in a prescription bottle.
The entire foundation for managing IC rests on these three non-drug pillars. And honestly, this is where your counseling can have the biggest impact. Smoking cessation, that's non-negotiable. A structured walking program is absolutely essential. And of course, getting those other big diseases, diabetes, high blood pressure, cholesterol, under tight control is paramount.
And this is such a cool point to share with your patients. It gets to the why behind the exercise. You can actually explain to them that by walking consistently, their body literally starts to build its own natural bypasses around the blockages in their legs. That's a really powerful concept to share. Okay, let's switch gears now and talk about the medications, but we're going to approach this with a pretty significant shift in focus, moving away from just thinking about the leg symptoms. This slide perfectly illustrates the modern way of thinking. When it comes to medications, our number one job is to save lives and limbs by crushing that systemic risk. Improving their walking distance, that's still important for sure, but it's really a secondary benefit. So treatment really centers on these four key drug classes. You've got your workhorses, statins, antihypertensives, and antithrombotics, all targeting that underlying atherosclerosis. And now, for our patients with diabetes, we've got a fourth major player in the game. This is a huge update for your practice. SGLT2 inhibitors like dapagliflozin and empagliflozin now play a really key role. Why? Because they've been shown to have this amazing dual benefit. They reduce both cardiovascular events and major limb events in patients who have both type 2 diabetes and PAD. Of course, when you're counseling, don't forget to mention the risk of genital yeast infections. And when it comes to blood pressure, the data we got from the SPRINT trial was so compelling. For patients with PAD, getting that systolic number down below 120 didn't just help, it actually led to a greater reduction in mortality compared to patients without PAD. It just goes to show how vital aggressive blood pressure control is in this group. All right, let's bust a clinical myth that just seems to hang around forever and often leads to clinicians not prescribing a needed drug. You've probably been asked this or wondered it yourself. What's the deal with beta blockers? The answer is a clear, resounding yes, they are safe. The old worry that they make claudication worse has been totally debunked by the evidence. So please, do not withhold these life-saving drugs from patients who need them, like someone who's had a heart attack or has heart failure. Next, let's quickly touch on the drugs that are aimed specifically at claudication symptoms. The main reason we're talking about these is because your patients might ask you about them by name, and it's all about managing their expectations. This table really says it all, doesn't it? Pentoxifylline offers pretty minimal benefit, and it's not recommended in Canadian guidelines anymore. Other drugs you might read about, like silostazol, well, they just aren't available here in Canada. The bottom line for us is simple. We've moved on from these symptom-only drugs. All right, let's bring this all home and put it together in a practical cheat sheet for your most important counseling points. We're going to focus on one of the trickiest areas, antithrombotic therapy. Think of this table as your go-to reference, and it's all based on evidence from that landmark COMPASS trial. For your highest risk patients, think people with diabetes or widespread disease, that low-dose rivaroxaban plus ASA is now the standard of care as long as their bleeding risk is low. For anyone with a higher bleed risk, you're looking at single-agent therapy, either ASA or clopidogrel. And here's a key pharmacy pearl for clopidogrel. Always remember to screen for interacting PPIs like omeprazole and esomeprazole because they can actually reduce its effectiveness.
So let's recap the key takeaways. Number 1, always connect that leg pain to the systemic disease. Number 2, your focus should be on lifestyle first. That's the most effective therapy. 3, when you use meds, you're targeting cardiovascular risk reduction first and foremost. 4, symptom-only drugs are out. And 5, life-saving drugs like beta blockers are definitely in. So I'll leave you with a final question to think about in your own practice. As this whole field rightly shifts away from just one symptom to treating a complex chronic disease, what is your evolving role as a pharmacist in coordinating care? Because your expertise in medication optimization and patient counseling for these incredibly high-risk patients has truly never been more important.